Hello. Good evening, all. We will be starting the session in another 5 minutes. Dr. Babu is just coming back from his work. In the meantime, pupillometry has attained a lot of attention in neurocritical care. One of the most promising tools to come up in the recent time to we can't say it will reach invasive ICP, but at least it gives you some information about ICP in a non-invasive manner in a very objective way. So that's the topic for talk today, and so we'll be shortly joining. All the FNCC students, by the time sir comes, may I just remind you, a gentle reminder to please enroll into the neurocritical care workshop for the February annual conference of ISCCM. I think the exam goers for the February batch This might be your only chance to attend the neurocritical care workshop. So please do so at the earliest. I hope you would have attended the ultrasound workshop. That box will be ticked, I hope. If not, keep a lookout for any ultrasound workshop that's happening and please get certified. Your exams will be probably in the first week of March after the annual conference. So please be ready for that. All right, I'm very, very sorry for, I apologize for the delay and thank you everybody who have waited patiently. Sir has been able to log in and now we shall start the session. Uh, so like I said, it's about pupilometry. Is it just a fad? The numbers and the promises, fake promises that so many of the other gadgets used in critical care have been? Or is it here to stay and give us some useful information for our bedside management? Let's see what the evidence talks about. So,
Hello, Shalini, can you hear
yes,
me?
sir. Yes, sir. Over to you, sir.
1 minute, I have to load this. I'm really sorry for what's happening. I'll have to load how do I load the presentation now? Uh, share, okay. The host isn't allowing sharing for this meeting. Why is that? Shalini, you'll have to allow me to share. Shalini, can you hear me?
Yes, sir. I'm just trying, sir.
What's happening? Your host isn't allowing sharing for this meeting.
Shalini, I think you have shared the whiteboard. You'll have to close it.
Yeah, that's right. Shalini, your whiteboard you have to close so that and give me permission to share. Hi, Bala.
Hey, Babu, how are you?
I'm doing well, man. Hey,
I'm looking forward to this because
I'm going to disappoint you because I didn't look it up any pediatric data.
that's okay. We'll extrapolate because we're getting a pupilometer and I have no idea what it can do.
Okay.
Do you use one, Babu?
We just got it 2 days ago.
Which one?
Neuroptics.
I think we're getting the same one.
Neuroptics IPI 300. NPI 300.
Neuroptics is that the one with where you have a consumable or
Yes, that's the one which has a consumable.
Oh, that's the one. No, I'm not getting that. I'm getting Neurolite.
Okay. So we are just looking at it. They've placed it. So
the consumable is quite expensive for that.
Exactly.
That's the one from Bombay. There, what's his name? Chetan is doing it. You know.
Yeah.
So, is it possible to share now?
No, the host isn't allowing sharing for this meeting. That's what it's saying. So I did not know how many, already 21 participants are there. Okay, so before we sort out the slide part, just to let you know what I have tried to do. There were so many studies using the quantitative parameter. It is a bit too overwhelming to look, and so I've picked up a few based on what evidence we have for use at the moment, and just trying to emphasize on that, and so that I can finish it within 25 to 30 minutes. So I have got 3, 4 or 5 studies, so it might look a bit boring. I'm the co-host now. Okay, so maybe yes. Good. I can. So, can
Not
someone help
working,
me out
Babu?
how I can share? Share. What is it? Allow. Okay. Okay. Open systems. Yes. Why is it asking me to sign in again? I'm already signed in.
Babu, why don't you just send your presentation to Shalini and then she can share it? If it's only like a few, you said 20, 25 slides or something.
Yes. Is that okay, Shalini? Shalini? Hello?
Shalini is not here. Oh, she's there. She's there.
Shalini? Hello, Shalini? Why am I not able to? Shall I get out and re-log in again? Will that help?
Why don't you do that? But you're the co-host now.
Yes.
So I don't know if you'll become a co-host or you'll become a standard, visitor. The other thing is, Babu, when I click on share, it says that I can request sharing and
Yes.
send request, and then the host has to authorize it. You want to try that?
Send it to you?
No, not to me. You just click share. Then does it ask you, does it give you an option to send request for sharing?
Let me see.
You can talk now.
So now are you able to share, sir? I couldn't log in. I just managed it now.
Oh, is that so?
So are you able to share your screen now?
No, I'm not able to share. I don't know why I'm not able to share.
You just need to share and you can give the consent.
Or Babu, send it to Shalini. Let her open it and share it.
Yes, sir. You can do
Is that okay?
Yes, sir.
How do I send it on WhatsApp or
Yeah, you can WhatsApp.
the slides to you? Okay, fine. Did you get it, Shalini? Shalini?
I've just got it, sir.
Yeah.
जैसे ही वो चीजें बाहर आती थी तो मेरी दादी हंसने लगी। यहाँ पर है सकते हो।
Okay.
I think I shared it. Can you all see the slide? But
Yeah, we can see it. We can see it.
I can't see the slide. Where did I go? What is happening? I don't know. I'm seeing myself. What the hell is happening?
You still can't see it, Babu?
I can't.
Oh, man. Babu, you want to send it to me by WhatsApp?
Let me see. Why is this happening?
Oh, no.
Let me try sharing again.
Or you can just share your screen and then you can open anything and just see that, and then it will be shared with everyone. So in case you are sharing, don't share as windows, share as screen, and then see the screen and go ahead with that. I think that can help if you're doing that right. Otherwise, you can ask somebody's help, or you can send us also. We will share it from here. No issues, sir.
Babu, what he said made sense, Babu. When you share it, it'll give you an option to share a window or a screen. You click on the entire screen. So whatever is there on your laptop will be shared.
Send it to us. We will do it. So, or you can share in the chat box. You can download and we'll share from here also. That is also.
I have rejoined. Okay, now what are you asking me to do?
There is a share button.
Yes, share. There is a share with arrow.
Click that share button, sir.
Yeah, clicked.
Now it will be giving some options. Share screen. If there is screen written somewhere,
yes, share screen.
then touch that.
Yes.
So click it. Then your screen will be shared. Now whatever you see. Now
Participants are able to see my screen.
Yeah, sir. You now join from Zoom Workplace app. This is your screen, which we can see here. So you can go with your presentation. Go to your presentation boss.
I have to sign into the Zoom Workplace.
No, don't do it, sir. Don't do it.
Okay.
Just minimize it. Go to your files wherever your presentation is.
Yes.
Okay. Please go to your file, boss. Minimize this. Yeah, that will be. Yeah. Now the qualitative pupillometry you might be presenting, sir.
Yes.
Yeah. Just double click it. Now the presentation mode, boss. Presentation mode. Yeah. The middle, the lower one, I think.
Your screen sharing. Stop sharing. Share.
No, don't go screen, sir. Presentation mode, or it is also seen. We
the presentation mode, right side corner.
Lower side, Babu.
Lower side, sir. Yeah.
There, go to the right. Go to the right.
It's written notes, then comments, then the left to comment. You can see something, sir.
Babu, move up. Yeah, now you go to the right.
Yeah, the cursor below your cursor, sir. Notes is written. Don't go so below, sir. Yeah, in this notes is written, sir. You can see.
No, I cannot see that. I'm not able to see notes. I'm only seeing my slide.
Okay, just go ahead with this slide also. No issues. We are able to see your slide, sir.
Yeah.
Okay, that's fine. Shall I? Yeah, shall I? Okay.
Yeah. There you go. There you go.
Great, sir. Now it's seen, sir.
Okay, Shalini, is it okay to go?
Yes, sir.
Please go ahead, sir. Thank you very much. I'm sorry I wasn't of much help.
No.
Doing great, boss. Thank you.
Okay.
Please.
Fine. Good evening, everyone. I'm extremely sorry for the delay caused by me for coming in a bit late and then having problem in sharing the screen. Okay, now today's talk would be looking at the evidence for use of automated pupillometry, automated quantitative pupillometry. And the question that I've been asked to answer is it changing practice or just another gadget? Okay. Unfortunately, I'm not able to move the screen. Okay, wait this. Got it. So let's go through a quick perspective of why we need to look at the pupillary reflex. Now, pupillary reflex, the aim of looking at pupilla has been built on physiology and has been described by early neuroanatomists and has been going on for decades, even maybe centuries. And we know from our clinical experience that pupillary size and reactivity served as a window to brainstem activity, autonomic function, intracranial pathology, and a lot of those things. So it is one of the vital parts of our neuro monitoring that we have been using for centuries. But the difference between the traditional method of monitoring the pupillary reaction and size and the automated pupillometry is qualitative, whereas the traditional way is quantitative. Okay. So earlier on, we were saying, are the pupils equal? Yes or no? Are they of approximate size? So we are saying, oh, it looks like 3 millimeters. Others will come and say, look at it and say, no, this is not 3. Me, it's more towards 4. And then whether it's reacting yes or no. A lot of times we know our nurses tell us you're sluggishly reacting. Others will say, no, it's not reacting. And then when we go and look, we think it is reacting. So it is very, what do you call it, operator dependent, and it is very qualitative. We could not quantify it. And that is why your automatic quantitative papillometry came in. Now, surprise, surprise, the quantitative papillometry was there as early as the 1960s. But that time the gadget was huge. The infrared technology that was available could not be moved around. So it is not available for everyone on the bedside. It is more of a research tool. It came into practice in the 1980s, and since 1980s, it has been used mainly by anesthetists and a lot by ophthalmologists, but never by neurophysicians and intensivists. So it is only since the 1980s that we have been using it. And what it measures, it actually measures multiple things. I will show you what all it measures in the actual screen of a papillometry, and we will discuss that. And what it measures the size. It gives us the contraction dilation rate, the velocity, the percentage of contraction that happens. That is, when they say percentage, they are calculating it with the what's the normal size, and then how much does the pupil contract, and then give it as a percentage. Now all these values we'll discuss as we go by. And in addition to this, there is a composite index called the NPI, Neurology Pupillary Index, which is commercially produced by the company. There are studies validating it. It puts in most of these values that the papillometry measures: the reactivity rate, the contraction rate, the velocity rate, the dilatation, the dilatation and contraction rate. All that put together, they got an index called the NPI, which has been studied quite a bit, and we will discuss that too. Why do we need it? It's to bring objectivity into our assessment. And as I said, it has been available on the bedside since 1989. Okay. Now, let's go to the first study, looking at how does automatic papillometry compare to standard pen torch papillometry. So is there any evidence to say one is better than the other, or are both equal, or are we just falling for a new gadget that has been produced? No, this is a study which came out in 2016. It was a prospective observational double-blind study from two neurocritical care units in France. Both the nurses and physicians were involved in the study. They did two things. One is, initially they did the device validation in 200 healthy people. So here the 200 healthy people were assessed by 4 physicians using an automated papillometry, and they wanted to know whether the values that they get, are they reproducible? Is there operator variation? Is it reliable? Okay. The other part they looked at is at 59 neuro ICU patients. They did 406 paired pupillary assessment. So they did pupillary assessment every 4 hours in this 59 patients. The initial one was done by the nurses. They selected 10 senior nurses who had at least 10 years experience in neurocritical care. And they did every 4th hourly the traditional pen torch assessment, followed by every 4th hourly assessment by the doctors who are using the automated papillometry. Okay, both were blinded to the others' results. and the doctors did a few hours after the nurses, so that they didn't know what the values were. So what did the device validation show? This is the device validation. Look at the scatter plot. If you can see the line at the center, the nearer the dots are to that line, it says that the values are correlating, they are reliable. And the two scatter plots you see, one on the top is for the resting pupillary size, and the one below is for the post test when the light is thrown in the eyes, and the maximum, the post dilatation size. So both of these tests shows very good correlation in 200 normal healthy individuals, saying that the readings you get from this machine are reliable, reproducible, and there is inter-operator concurrence. So what they said, AP is reliable, reproducible, and has a good inter-observer agreement. So that was established first. Then they went on to do the other part of the study. They compared the values that the nurses produce and with what the pupillometry. Now, if you look at this box diagram, what is clearly showing you is what was the agreement between the nurses and the doctors at the various the pointer, if I can get the here's the pointer, at the various sizes of the pupil. Okay, so from 1, 2, 3, 4, 5, 6 millimeters, if you see, the larger the boxes, less the agreement. So what's clearly telling us is we as nurses or doctors are very good in measuring the pupil size correctly when it is either small or large. There's agreement with that. 1 millimeter, small pinpoint pupils, we are able to pick up. Large dilated pupils, we are able to pick up. But in between the 2 to 5 millimeters, that is the range that most of our patients are going to come in with. There we are poor. There the correlation is very poor. Not only that, when they did the analysis, the limits of agreement was very wide. Okay, minus 2.11 to 1.39. So this, especially in the range between 2 to 5 millimeters, there was no correlation between what the nurses read and what the pupillometry picked up. So the clinical takeaway from this was that standard technique is least accurate where the accuracy matters most, that is 2 to 5, not once the pupils are pinpoint or not once the pupils are blown out. And even a 2 millimeter error can easily create or miss anisocoria. We will look at the study and see how good the nurses were at picking up anisocoria compared to pupillometry picking up anisocoria. Okay, so that is the first one. The second one, ROC curve, same thing it is showing. When the pupil size is at its extremes, less than 2 millimeters, greater than 2 millimeters, the traditional method has a good area under the curve, about 86 to 90%. Whereas when the pupil size is between 2 to 4, the area under the curve is really poor. Almost, if you look at the ROC curve, this one is almost lying on the central line. It's only about just going to 60%. So the takeaway again is visual examination is poor at the extremes. Poor at estimating true pupil size when it is 2 to 4 millimeters. Sorry, at 2 to 4 millimeters. So it is that 2 to 4 millimeters or 2 to 5 millimeter range that we are poor at picking up and giving the right thing. Now, this is looking at anisocoria. The pink part of the diagram shows the anisocoria picked up by the nurses, and the white part shows the anisocoria picked up by the pupillometry. Okay, so pupillometry detected 30 true anisocoria in these patients, while the nurses picked up only 15. So they missed 50% of the patients. So this is very concerning. Okay, we are missing that's all. And they described anisocoria as any difference in pupillary size of greater than 1 millimeter, And the previous child had shown that when the nurses looked at it, up to 2 millimeters change difference was being missed. So that is why almost 50% of the anisotropy was being missed. And what is more surprising, but the standard method also had 16 false positives, which is again very concerning. If you rely on a nurse's records and say, oh, anisocoria, and actually patient doesn't have anisocoria.
आपका चेक इन किया हुआ सामान आगमन हॉल बैगेज बेल्ट नंबर 4 पर उपलब्ध.
Okay, someone has not switched off their mic. Okay, fine. So that is also a bit concerning. So clinically significant anisotropy is missed by the traditional method, and false positives may also occur. So a lot of our patients may get unnecessary CT scans and procedures if we are getting false positive anisotropy. So that was also thing noted in the study. So what was the takeaway message from the study? Poor correlation between the standard and the pupillometry in pupil size assessment, especially in the 2 to 4 millimeter range. Okay, standard method is poor in estimating the true pupil size when it is only 2 to 4. I told you area under the curve is roughly around 60%. The standard method can miss up to 50% of anisocoria. That's what the study showed. And the standard method produces significant number of false positive anisocoria. The other thing that they showed, which I didn't put up, is that the standard method was also poor at picking up the pupillary reflex, pupillary light reflex, with the error percentage of 18%, especially in the 2 to 4 millimeter range. So the 2 to 4 millimeter range, where the pupil size is almost normal, is where I think we are poor at picking up the traditional method. When it comes to size, when it comes to difference in size, or even when it comes to the pupillary reaction. So with this as background, let's look at what a pupillometric measuring can give us. Now, this is the equipment that we have just got into our department. Dr. Bala was saying that he is looking at another department. This is called the NeuroOptics NPI 300. Okay, we're just trying it out. So this is actual reading of one of our technicians. I wanted to have a look at it on the left eye. So as I told you, NPI is an index that this company has produced after research, which incorporates a few of the other parameters they are measuring. So what does the pupillometer measure? It measures the size, which is a resting size, okay, in millimeters. Okay, the technicians was 2.92. And then after you start the procedure, it shines light into the eyes. It measures the size, the contracted size. Okay, that is the minimum size. Now, CH is nothing but the ratio or the percentage of change. How much did the size drop from the original? So from the size dropped from 2.92 to 2.33, and the percentage of that is the CH percentage. CV is the rate at which the contraction happens. MCV is the maximum velocity of the contraction, and LAT is the latency. What is the time taken for the pupils to actually start contracting or dilating? Okay, that is the latency. And DV is the dilatation. So after the light has been, when the pupil re-dilates, what's the velocity? So these are all the fancy numbers coming out. And how are we going to use these numbers? Which numbers are useful? These are the things that we are going to look into. Okay, and what is considered as a normal range is what I'm going to showing you in this slide. This is what the company has put up. NPI is an index which has been studied and is being continued to be studied. As per the company's recommendation, what they have seen on the study is the number goes from 0 to 5. So 3 to 4.9 is considered a normal pupillary reactivity, NPI. Less than 3 is abnormal, and the less it becomes from 3. Like if it's 0, that means the pupil is not reacting at all. Okay, the worse is the pupil reaction. Okay, that's NPI's value. The others are all given the HMI. Only thing I put out is the CH percentage. Now they said it can be 0 to 50%, but most of the studies use a 15% change as an acceptable a change in pupillary size. Anything greater than 15%. That's why I put the 15% there. If it can go as high as 40%. So in the study that we talked about, the healthy subjects, their pupillary size came down to as low by as 40%. Okay, but anything greater than 15% was considered normal pupillary reaction. That's what you need to know. Okay, so what are the clinical applications for which quantitative pupillometry has been studied? I'm going to stick to 2 main areas. That's where, sorry, someone's mic is on. I can hear someone scolding the child. Okay, can you switch off your mic, please? Okay, so one of the areas where pupillometry has been studied is in traumatic brain injury, to see whether the indices or the values that you get from the automatic pupillometry would coincide with the ICP. Can you use it as a prognostic matter for outcome? And there is one new study which has looked at, can we even look at these markers to say whether to pick up the mild TBI. I will do the first 2. I might not touch upon this because it's a ER-based small study. I'm not going to touch upon that. The other one where there is, I would say, a good evidence is in post-cardiac arrest to prognosticate the outcome. There is a meta-analysis on that. I didn't want to go through the various smaller studies, so I took the meta-analysis, which is published recently, as recent as about a year ago. I don't think there's any other big study which has come out after that looking at the role of pupillometric readings in post-cardiac arrest. Now, in stroke, there are studies looking at whether this can be used to prognosticate outcome from stroke. And there are the fancy ones going at assessment of pain in ICU. There is a worry that pain can influence the pupillometric readings, so maybe it not be accurate. So they are looking at how we can make use of that to assess pain score rather than using the usual pain chart that the nurses use. How to detect covert consciousness, and also as a tool for helping us design brain death. I will not be touching on these. So let's look at this pupillometry for monitoring ICP. How good is pupillometry for diagnosing raised intracranial pressure in patients with severe traumatic brain injury? This is a prospective observational study. The objective of the study was to look at the association between raised ICP and automatic pupillometry, derived data in severe TA. Okay, all patients had GCS less than 9 and had invasive parenchymal ICP monitoring and were at a risk for intracranial hypertension. So the subjects were mainly severe TBI, abnormal head lesions. So CT scan showed focal lesions like SDH, contusions, all that, and all of them had invasive ICP. Okay, they had totally 54 patients were studied. A median of 78 readings were done with the intercortical range of 47 to 108, and mainly focal injury TBI subtypes. So 74% were SDH. So they didn't look at diffuse head injury. I mean, they had patients where numbers were less. More of them were mainly localized, like contusions and SDH. Okay, and there was a high prevalence of intracranial hypertension because of the monitoring with the bolt in the head. Okay, so and there were 43 episodes of sustained elevated ICP recorded because of the use of bolt. Now let's look at these 2 graphs separately. Okay, the one on your left hand side is looking at the trend of ICP and the trend of NPI. Okay, the index that showed the neurological pupillary index. Now, if you look at it, you will see that as the ICP goes up, the NPI keeps steadily coming down, and the 2 stars indicates where it is it's statistically significant. So the moment ICP even goes up to what we consider, it's not raised ICP, there is already a small drop in the NPI from 4.2 to 4. Okay, remember that all studies use NPI less than 3 as a marker of poor outcome or raised ICP. That's what they're trying to extrapolate. But in this study, by the time it comes to 20, the NPI is 3.5. And by the time it goes to ICH level, it has come to 2.8. So there is a correlation between ICP going up and NPI coming down. Okay, and that is statistically significant. What happens when you give osmotherapy? The moment you give osmotherapy, you see the NPI starting to go up. And when the ICP comes down from 30 to 12, the NPI goes back to 4. So indirectly telling us that this maybe can be used. We'll look at more evidence. Maybe can be used for early detection of ICP going up, and also look for response with therapy. What I didn't show in the previous chart is the monitor in the pupillometric device that I showed you. In addition to having this numbers as an IP, has got graphical representation which continuously plots each reading you take. So you can have a visual graphic representation of what is happening to the NPI with each reading. If you see it decreasing gradually, that should make your antenna go up, saying that something is going wrong. So there's visual, in addition to number, there is also graph, like in ventilators, how you have graphics to give you a better visual impression. Okay. Now, this study also looked at what is the correlation with outcome, 6-month outcome, and the recorded NPI. And look at what this graph is showing. Everyone who had the Glasgow outcome score, extended score, okay, of less than 4, that's why we can consider bad outcomes, isn't it? 3 and 1 had a much higher, or I mean, much lower NPI. Okay, so again, this study, they were not actually planning to look at it, but that's what they also found, that if your NPI is low, okay, your 6-month outcome is also poor. So what's the takeaway from this? Sustained elevations of ICP greater than 20 millimeters are associated with concomitant decrease of quantitative NPI. Treatment of elevated ICP with hyperosmolalgia was associated with normalization of NPI, and failure of NPI to recover to normal value was associated with very poor prognosis. So a small study which is showing that there is some, something pointing towards pupillometry, especially NPI and ICP and outcome. Okay, that's one. So this is one of the newer studies, a larger study, a more complex study. Took me some time to get my head around it. This again was looking at NPI, and it looked at how good is NPI to prognosticate an outcome after acute brain injury. Okay. The other study was a small study and was not actually, the primary aim was not to look at the outcome. So this study was looking at the outcome. So this is a prospective multicenter observational study. Patients enrolled had acute TBI, intracerebral hemorrhage, subarachnoid hemorrhage, all requiring ICU, intubation, mechanical ventilation. So this is just not trauma alone. We also have subarachnoid, aneurysmal subarachnoid, and ICH in this group. The objective was to look at 2 primary endpoints: functional neurological outcome and mortality assessed at 6 months post-injury. Just to give you an idea of how there are 514 patients, 44% was TBI, 27 was subarachnoid, and 29 was ICH. So roughly, if you put it, 50% was TBI, other 25 was subarachnoid and in the cerebral range. And they also saw that at 6-month outcome data was available in about 97. The alive patients where the Glasgow outcome score was greater than 4 was about 40%, and where the Glasgow Coma was less than 4 was about 60%. So 40 and 60. And out of the 60% with low Glasgow score, 32 died. Okay, these were the data. So they did large number of pupillometric readings. They did pupillometric reading every 4 hours from the time of admission for up to 7 days. They had around nearly 8,000 readings. Okay, so people median of about 40 measurements per patient is what they did. Now I just put this table just to show they used a complicated statistic method. You know, it's like one of our recently discussed studies. What is the hemodynamic study where they used confusing statistical. This also did that. But what they showed clearly is model 1, that is where the NPI was looked at less than for a poor outcome. There was a significant increase in poor outcomes. You know, odds ratio is 1.4, 1.42. So they had 1.42 times more risk of getting poor outcome. Okay, so a low NPI was seen in these patients, and they had a poorer outcome. Okay, so let's see what the takeaway. So what they saw in this group of patients is they had repeatedly abnormal NPI value in the first week, and that was a poor predictor of outcome. This is in the group who had a Glasgow outcome score, extended score of less than 4. Okay. Abnormal NPIs, that is less than 3, again I'm telling you, and NPI values of 0, if you got it, was more seen in the patients with a GO score of less than 4, and an increasing number of NPI readings over time was associated with a poor outcome. So if with treatment your NPI numbers did not improve from less than 3 to about 3, the outcomes was. And they also noticed that if you had 2 consecutive NPI numbers equal to 0, or if the number deteriorated to 0, mortality was increased. Okay, and the mortality risk was not increased. Okay, they didn't say the mortality was better, but they say it did not increase if the NPI improved. So again, telling us, like with the osmotherapy, if your NPI improves with treatment, better chance of recovery. If the NPI does not improve, remains around about 0, more death. If the NPI drops during the therapy, worse outcome. Okay, so NPI values between 3. This is the other interesting thing. They found that even though the studies used the NPI value less than 3 as abnormal, they found that even when there is a drop of NPI less than 4, the mortality increased. So NPI values between 3 and 4 were also associated with greater risk of mortality than values above 4. Okay, so again, something for us to think. If you are treating a patient with traumatic brain injury, and if you have the luxury of having a pupillometry and you're looking at NPI, look at the trend, and if the trend is not dropping, it's above 4, you're okay. If it is starting to come down, it's coming down before 4, that should make you act on it, because there is some evidence that when it starts to drop below 4, between 3 and 4, that mortality can increase. And below 3, definitely bad outcome. You have to treat them aggressively to try and get the NPI above 3, and as it improves, the outcome also becomes better. Okay, that's what has been shown. Okay, so these are the 2 studies that we have looked at traumatic brain injury. I need to tell you that this orange trial, the group that did the orange trial, yes, they did a secondary analysis of the group of patients. They didn't have ICP monitoring device in all patients. So they did a secondary analysis in the group of patients who had the ICP monitor, and then published it as another study just few months ago. I think it was it came out in September, October, looking at whether there is a correlation between NPI and ICP, which the small study did show. Surprise, surprise, this bigger study hasn't shown that correlation. Okay, it is not statistically significant. That's how I should put it. Fine. Now, that is about the traumatic brain injury. Now, as I said, there are a lot of studies that looked at pupillometry in post-cardiac arrest prognosis, neurological prognosis of post-cardiac arrest. This is the meta-analysis which came out in 2025, and it has 12 of these studies, 1,530 patients in it, and the objective was to evaluate the association with QPLR. Now, QPLR is nothing but the percentage of change, what we call the CH in the pupillometry that I showed you. Okay, the neuro-optic. So CH is the percentage of change that happens, when you're doing the pupil reaction. So QPLR is nothing but quantitative pupil reaction. Okay, that's called QPR in other pupillometers. So they looked at that or NPI and looked at the neurological outcome in cardiac arrest patients. So these are the 2 things that have been shown. As I said, there are many other parameters, but the NPI and the QPLR, that is the percentage of change in size, have been studied the most to look for with the neurological disease. So out of those 8 studies, we're looking at QPLR and 7 studies at NPI. So let's see how they look at it. So the QPLR data, okay, I want you to concentrate on the studies. Just look at the forest plot. All studies are falling onto the right-hand side towards the side of harm. Okay, all 8 studies clearly telling us that if the ratio of reactivity is less than 15%, the chances of neurological recovery is poor. Okay, and it has an odds ratio of 24.5. Can you imagine that? 24 or 25 times more likely to have a poor outcome compared to a patient who has a QPLR above 15%. Okay, the ROC curve shows that it has a good area under the curve, about 90%. Again, just keep this in the back of the mind. Look at the specificity. Specificity is about 96%, whereas sensitivity is only 54%. Okay. How about NPI? If you look at the NPI, again, the study, if you look at it, the same trend. All studies fall onto the right-hand side, telling that all showed harm if the NPI was less than 3. Okay, but here the confidence interval is less than the one for the QPRL, and the same thing, the area under the curve is less than the QPRL. Even though the specificity is 99%, the sensitivity is extremely low, 24%. Okay, so this is what the meta-analysis shows. So what is the takeaway from the meta-analysis? Both QPLR and NPI are good tools for predicting neurological outcomes after cardiac arrest. Okay, QPLR has a greater diagnostic accuracy in predicting neurological outcomes than NPI. Both QPLR and NPI have near perfect specificity, 100%. So if it is positive, that is means if your QPLR is less than 15% and your NPI is less than 3, the outcome is highly likely to be poor. However, sensitivity is poor, so there'll be a lot of cases that you can miss. But if you all know, if you want a test to be a diagnostic, the specificity has to be good. So it makes a good test for prognostication. So as long as you don't tend to miss patients, if it is positive, I mean, NPI is low and QPL is low in a patient after post-cardiac arrest, their chances of a good outcome is extremely low. That's what I'd like to tell you. Okay. The problem that the meta-analysis has brought out is the optimal time to measure these parameters. Okay. All these studies used at different timings. Some started immediately after the arrest, some started 24 hours after, others started 72 hours after the arrest. Okay. So the meta-analysis didn't tell us what time. Okay. So these are the 4 studies I wanted to look at. I then looked at if there is so much of studies going around and being published, have any of the guidelines taken up this and recommended as something that we should practice? I could only find one guideline. It's post cardiac arrest care 2025. Okay. Now I do not know whether you can see the cartoon, but the cartoon clearly says what are the things we have to do after ROS for neuroprognostication. Okay, so in the first 24 hours, what are the things we can do? In the first 48 hours, what are we supposed to do? And after 72 hours, what are you supposed to do? And in that after 72 hours, you have got pupillary reflex and your pupillometry. Okay, so that is where it has come in. So use of pupillometric devices in post-cardiac care monitoring for prognostication. Neuro prognostication has become a sort of standard of care as per the guidelines. So what it says, when performed with other prognostic tests, it may be reasonable to consider quantitative pupillometry at 72 or greater than 70 after cardiac arrest to support the prognosis of unfavorable neurological outcome in adult patients who remain comatose. I did look at trauma. Even the European guidelines for post-cardiac arrest has included this. But in trauma, I did look at it and I couldn't find anything. The BTS guidelines, the 4th edition, has not mentioned. I think it is it came out a bit much earlier, so maybe the recommendations will come in later. I did look at the ACS, American College of Surgeons. They have brought out the 11th edition of the ATLS manual. So I looked at their management of traumatic brain injury and went through that neuroprognostication monitoring chapters. They have not mentioned it either. So it has the use of quantitative pupillometry in traumatic brain injury has not been incorporated in guidelines yet, whereas this cardiac arrest, post-cardiac arrest neurorecovery prognostication has been used. Okay, so what are the limitations? Okay, the limitation mainly is we do not know what the effect of sedatives would have on the sedative and analgesics. So there is a strong feeling that patients who have sedatives and analgesics, which for most of our patients would be having neuro critical care, that the actual value that you measure may not actually correlate with the ICP. That's one concern that most studies are needed to look into it. And of all the parameters, the NPI seems to be less affected by these medications. The other things are the confounders. Most of the confounders here, we do not know how they will interact. Cranial nerve diseases, when I say diseases, it can be any disease. And most of the studies excluded patients with known facial injury where the nerves can be injured, and other neuro problems affecting the pupillary pathway. Okay. There's a concern whether hypoxia can affect the values, hypercarbia can affect, whether difference in circadian rhythm can affect the ambient light. Yes, that is another thing. So most of the studies, what they did is to get away with the ambient light. Most of it has a close-fitting cup which sits onto the eye that you are testing, so that the ambient light doesn't enter through the sides, and the other eye is usually shut. Okay, we use a pad, a gauze pad or something, and shut the eye so that ambient light doesn't. And then and again, pain. As I said in the beginning, pain has been shown to change the values that we get, and there are studies looking at if we can make use of this to assess the degree of pain and use it to quantify pain. Okay, so studies are going on this. So with that, I conclude saying that what's the conclusion? AP is a new kit that is generating interest in neuro ICU. There is evidence emerging that it's a good prognostic module in neuro recovery after cardiac arrest. Its role in monitoring ICP and prognosis in trauma, I forgot to put it, in trauma patients is still debated. There is no clear guidelines on that, on which parameter to monitor. NPI has been studied a lot. QPR has been studied a lot. There are studies which looked at contraction velocity, dilation velocity, pupil size, all that. So again, no consensus on it, but NPI and QPR are the most studied. When to monitor this? Should we do it immediately after the incident or sometime a few hours after? In traumatic brain injury, it makes sense to start monitoring from the go, continue monitoring, because you need continuity to see what's happening. Whereas in post-cardiac arrest, we don't know. Does it make sense to do it before? I think later studies will tell us that whether it was going to help us predict outcome better if you start. But at the moment, the recommendation is to start after 72 hours. And how to monitor these parameters? Should we do it every hour, every second hour, every 4 hours? So as I said, the first study used every 4 hours. The second study used it every 2 hours. Or should you do it continuously? Like, cardiac output with the PA catheter was done intermittently. Then we came to continuous cardiac output monitoring. Same, maybe, technology will change and we can get a continuous NPI sometime later after a couple of years, which maybe help. I don't know. So I conclude with these doubts and questions with the take-home message that the only guideline which allows us, or tells us to use quantitative pupillometry is post-cardiac arrest. Rest are still in a research field. Thank you.
Thank you, sir, Dr. Babu. It was worth the wait, I must say. It was a wonderful review of all the existing literature. One of the worrying factors is this instrument has been there for more than a decade and it's not become as widespread as it should have. That already raises a few red herrings. What's happening? Why is it not gaining popularity? This was one very good review, sneak peek into why things have not been as bright as it was promised to be when it was launched. The forum is open for questions. Please go ahead, ask as much as you want before sir leaves.
No, I hope you don't ask how to use it, because I myself have not used it. I will only use it for 2 days.
Don't worry, sir. I have used. I'll fill in for you.
Thank you, Babu. That was very, very useful introduction, because I knew very little about pupillometry, until I listened to your talk. And I'm happy to say that a quarter of today's participants are from my unit on this group. I think that what I understand from what you said, the two very important uses. One is you mentioned how inaccurate humans are at measuring the pupillary size between 2 and 4 millimeters. And that is something which would be very important for us. It's very easy to use. The model which you have, I think it has a proprietary cup for each patient.
Correct.
And you can't use it for another patient. They want to make sure that you buy more of those.
Correct.
The model that we are planning on getting has a reusable silicone cup, black silicone cup, so it cuts out the ambient ambient light, and so we can put one at each bedside, and instead of the nurse basically looking and saying, "Oh, this is 2 mm, this is 3 mm," then change of shift, and then another nurse comes. There's a lot of subjectivity involved, so this will make it objective. And the other thing you had mentioned was with the correlation with raising ICP in those patients who had ICP monitoring. And yours was called what? The QPI, right?
No, one is called NPI.
Oh, yours was NPI. The one
yours may be QPR, quantitative.
No, the one that in the index on the model that we are thinking of getting is called QPI, Quantitative Pupillary Index.
Okay.
But it goes from 0 to 5. 0
Correct.
to
So it's
1
the same
is very poor. It's about the same thing. There's also another model which I didn't want to get. It measures, you mentioned that briefly, the pain, a level of analgesia.
Right.
But this is the basic pupillometer. And I think one reason why they're not widely used is they're quite expensive. I don't know how much yours is.
Correct.
It's, how much that costs. So the one we're planning to get is about 8 and odd lakhs.
Wow. Okay.
But no consumables,
Okay.
which get to be billed to the patient.
Correct.
Okay.
Yeah. So I agree with Bala. I think the good thing about this quantitative pupillometry is it takes away the inconsistency that we have with the human, and looking at the light. So it gives you a correct number, which in the 2 to 4 range becomes very important. So that is going to be very important. Yeah.
The other thing possibly is, we've had patients with either a metabolic encephalopathy or a infective encephalopathy or a TBI, and not everybody gets an ICP monitor. So those patients where we haven't had monitors, we finally see one pupil getting larger, then we rush for a CT, and then we call the neurosurgeon and do a decompression. Maybe this will hasten that process. It'll give you an earlier warning.
Correct. Very true. Very true. Very true. I mean, I think we need more studies for that, because as I mentioned, the one study that showed a correlation between the NPI and ICP was a small study. The big study, the secondary analysis, didn't show that correlation. So we really don't know, but there is something there. I'm sure it is there. We need to just keep monitoring and following it up ourselves to see how it will help us.
So there is one.
Dr. Ravi Kumar.
Yep.
Dr. Ravi Kumar from Chennai, basically, sir. So being this pupillometer doesn't get affected by interpersonal observations. So it is going to be same for who is going to observe. So whether any of that factor was looked into any of these studies, sir?
Yes.
Because TCD, ONSD, all those will have definitely interpersonal observation variations can be there. Correct. So here even a nurse who's going to monitor the bedside is going to give some ideas, and the trends may be useful when you have a device like this.
Yes. I mean, the first study I clearly showed that. The first study, which I said, they had evaluation of the device of 200 healthy people, readings done by 4 doctors, and they clearly showed that there was very good correlation between every reading taken in both resting pupil size and the constricted pupil size. So there was good reproducibility and good interpersonal, correlation. So what you said is true. The lack of not having a value and having the change in value with the observers is taken away.
One of the reasons for this is with the use of pupillometry, it is very, very objective. There are two pinpoints, white colored dots, which have to be on the two ends of the iris. And then the light is held constant for 4 seconds, and only then it shoots. So there is a lot of objectivity to the whole process of measurement. There cannot be any variation.
Which one do you have in Vellore?
Sir, we have Neurolight, the QPI one.
Okay.
And Bala sir, who is planning to buy that, there is one caveat to this instrument. It doesn't have the dilatation velocity. So it
Okay.
will
Oh,
not
I
be
see.
as
Okay.
good as NPI, the Neuro Optic, that is the original version. Neurolight does not have dilatation velocity.
Okay.
I had this rude reminder because in one of our journal club, we had an article assessed for dilatation velocity as a predictor for poor outcome in malignant MCA infarcts. In fact, when NPI and dilatation velocities were put together, the p-value increased, the sensitivity increased much more. So we went ahead and checked it. Dilatation velocity doesn't exist. You'll have to manually do it. It can be done, but you'll have to manually measure. So that's a little bit
Okay.
off.
Okay.
But then you have, if you have post-op patients a lot, you can do the pain score. That is useful.
Yeah. So I didn't go into stroke and pain score because otherwise it'll go on and on and on. And I thought I'll just stick to the two important areas that we see. That's one.
There's one question for you, sir, in chat box.
Yep.
They are asking about pediatric experience. Does the literature say anything about that?
No, pediatric. I told you, the only thing I can tell the guy is the only thing I know about pediatrics is to cry with the mother when the baby is sick. I'm a full adult. I'm sorry, I don't know. I have no idea. I didn't even look into it. Didn't go into my mind to look into pediatric literature. I'm very sorry.
No, that's okay. But I was just, while you were talking, Babu, I was looking at the publications presented by the Neurolight people, and they do have some pediatric data, and it's by an Indian person.
Okay.
I don't know where he's from.
Okay.
Natarajan or somebody. It's there. So there are data, and then I think once we have the unit, then we can produce some data from our own unit. And in fact, Ravi, I have a great idea for a thesis, so we're just waiting for the machine and the new fellows to come. Yeah. Shalini, actually, when I was talking to the supplier and I asked him where he's installed it, he said CMC, All India Institute, and NIMHANS. And I said, well, if it's good enough for CMC, it's good enough for us.
Yeah, we've had some good experience. Like you said, it at least forms an early shift for CT scan and thereafter decompression. So yeah, we do not have the final answers, but at least it's given us some uniformity to every hourly monitoring, and that's something to start with. I think there is one more question in the chat box which asks any side effects with pupillometry. Babu, so you would want to answer that?
I really don't know. I didn't read through any side effects that is really don't know. I mean, if I try to tell, I'm guessing and I'm trying to be professorial. So no, I didn't read. No, they only all studies only talked about limitations. Nobody wrote about any side effects because the light, they have even given what sort of light, what luminance, and the infrared, what range the infrared. So there was no side effects reported in any of the studies I went through. Sorry.
We have not. There is one thing, Dr. Ravi, that you, from the side effect point of view, The nurses are so paranoid about touching anything and causing infection. In fact, I found one of the nurses not touching the uh, screen, the thing for cutting off the outside light. They don't touch it on the skin. They hold it back, and then there is an inter-observer variation. So that, if you want to take as a side effect, infection might be a problem. But you should be ideally using a single cap for every new cap for every single patient. Other than that, we haven't faced much of a side effect.
But these caps are autoclavable, though.
It
So
is, but it
yeah.
becomes a little, fiber becomes a little rough by second and third autoclave. It's not
Oh, okay.
as soft as the original one.
Okay, then I won't autoclave it. I'll just clean it with whatever, with some.
For corporate, that the amount will be peanut. It's not that expensive.
It's about 4,000, I think, or something like that. But
Yeah.
Babu, your unit, the one with Chetan Nair is
Trying to
giving or trying to sell, but the consumable is quite expensive.
It is. So the consumable, each cup is 2,500 rupees with MRP sitting at 3,500. He said 2,000, MRP is 3,500.
Now, the device itself, I think it's cheaper, but
Yes, device is cheaper.
yeah, but my patients can't afford, I don't want to put 3,500 rupees onto each patient's bill. So, and they're very smart. They put a chip in there so that you can't, reuse it or whatever.
Yeah, very true. Any other questions?
Yeah. Sir, I'm Vivek Mitra, sir, from Jaipur, Rajasthan.
Yes, tell me.
Sir, my question is, it's regarding one of my friend's mother who had TBI. Okay. So we were looking at what were my questions is, after craniotomy, we definitely always do pupil reflex, pupil light reflex. How intra-observer variations or how effective it is in getting to know the use of pupilometer? First question. Second question relates to the procurement of the device, if it's that good, and the cost.
Okay, the first one, again, the study that I looked through, looking at the pupillometry, patients have been taken up for control of ICP. Osmotic therapy plus minus decompression has been done. But we have not mentioned, otherwise I have to go deep, because I didn't go deep into it, looking at methodology and things like that, whether they stopped monitoring them. But, after the study, I don't think, because the second study, which had the same sort of protocol, continued to monitor them for 7 days. So even after the craniotomy, they should have monitored. Otherwise, you cannot come on, monitor for 7 days. So I don't think it changed much. That's one. Second thing, okay, Dr. Bala did tell you about the NeuroLite. He said it is about 6 or 7 lakhs? 8 lakhs. 8 lakhs.
That's a quoted price.
8 lakhs. The NeuroOptic, NPI 3000, what they quoted, the company quoted to us is 6 lakhs, 5.9 lakhs. But as Dr. Bala said, the cup that you attach to it, they have made it in such a way that each cup has a chip in it. So once you use it for one patient, all patient data goes into the chip. So you can't use that cup for another patient. So you have to buy one cup per patient, and each cup can only take 160 paired readings. So 320 readings, paired readings can take. So that's all it can take. So each cup is 3,500 rupees. So you have to buy each one cup for a patient, or if you are doing more than 160 paired reading, then you have to buy the second cup too. So that is the only thing. So these are the two models. I only know about the NeuroOptic, but Bala said about the NeuroLite.
Okay. So NeuroOptic, whom to procure, sir, the vendors or something?
NeuroOptic, if you know Mr. Chetan Nair, he's in Mumbai. You will know Chetan Nair. He used to be the one of the patrons for ISCCM. He's very much involved with ISCCM. Chetan Nair, his company's name is
Hansraj.
Hansraj Nair. Yeah.
Correct. Hansraj Nair.
Okay.
Yeah, that's right.
He'll be there at ISCCM. He comes to every ISCCM.
Okay.
Hansraj Nair is the company's name.
Yes.
The proprietor is Chetan Nair.
Nair.
Nair, yes. Not Malayali Nair.
He's not Malayali Nair. Yeah.
Yes. Not
Punjabi Nair.
That's a really good insight, sir. I was looking into SNCC and I was about to ask about this, and Dr. Shalini has mentioned that we have a talk tomorrow, and I'm really delighted and excited to join it. Thank you very much, ma'am. Thank you all.
Thank you.
Thank you, sir.
Thank you.
Thank you, Babu. That was very useful. Very useful.
Thank you. I hope I can now switch off this. I won't have problem logging off.
Good night. Thank you, everybody, for attending this session and making it so lively.
Thank you.
Good night.